Hello and welcome to another tutorial. This one is about Alzheimer's disease with a particular focus on the gross anatomical changes that occur with the disease and talking about some of the symptoms as well. Before we get started on Alzheimer's though, we're going to just try and categorise different types of dementia. So we're going to start off by making three categories. So we're going to have primary degenerative disorders. We're going to have vascular dementias. Write that properly. Here we go. Vascular dementias. And lastly, we're going to have secondary dementias. So let's talk about each of these in turn. Primary degenerative disorders is the group in which Alzheimer's disease falls into. Also falling into that category would be frontotemporal dementia and also dementia with Lewy bodies as well. So primary degenerative disorders are types of disorders which are progressive. They are the disease is the dementia in its own right. The second group are vascular dementias. Vascular dementias are obviously defined by a problem associated with the blood vessels supplying brain tissue. So often we find that there's disease of the blood vessels supplying the brain tissue itself. So with these we tend to find that they either affect the large vessels, which are supplying areas of brain, in which case we get what's known as multi-infarct dementia, or we can get problems associated with the smaller vessels, the perforating vessels, and in that sense we can sometimes get what's known as TIAs, which are transient ischemic attacks, which are periods of time when the brain is starved of the oxygen and nutrients that it needs, and therefore we see symptoms as a result of that. With primary degenerative disorders, often we see a very telltale sign and an orderly fashion in the way in which symptoms will come about in a sequential manner. With vascular dementias, it's very variable. With multi-infarct dementia, with large vessel disease, obviously, depending on which vessels are involved, will have different onset of symptoms every time. Again, with transient ischemic attacks, we're likely to see a variety of symptoms, no sort of telltale sign in terms of the orders of the symptoms that can tell you that it is particularly vascular dementia. The only thing between them, I would say, is that while primary degenerative disorders tend to be slowly progressive, sometimes not so slowly, vascular dementias tend to be more stepwise in terms of their decline. So we'll often see a very fast, rapid downturn in the patient's cognitive or neurological ability. So that's vascular dementias. It's also worth adding to vascular dementias, including, particularly because this is about anatomy as well, is that it depends on the circulation to the brain. So if it's the anterior supply, so if it's the anterior circulation from the internal carotid arteries, then that will obviously have a different onset of symptoms if it is compared to the posterior circulation from the vertebral arteries and the basilar artery. Secondary dementias are dementias which are due to central nervous system issues or other systemic pathology. Examples might be things like hydrocephalus. So let's put that in there. Hydrocephalus. We might have deficiencies, so we might have B12 is a common one, and many of these types of secondary dementias would be reversible, unlike vascular dementias. Well, vascular dementias might be if they're transient ischemic attacks, but certainly primary degenerative disorders are not reversible, and that's where a great deal of time and money is spent in terms of research. Let's focus now more on Alzheimer's disease itself. So Alzheimer's disease is the most common type of dementia, and it probably accounts for about 50 to 60% of all types of dementia. So all cases that involve dementia, 50 to 60% of them will be Alzheimer's. Alzheimer's was once thought to be an inevitable aspect of ageing, and for a long time, actually consequently, it attracted very little interest in the research community. But over the last decade, there certainly seems to be more of an interest. It seems to be something that could be treatable, something that might even be able to be avoided. Lots of more research has gone into the neurochemical aspects of it, the pathological aspects of it, and also the genetic aspects of it. And because as a generation, as a population, we're living longer, we're seeing more people with the disease. But of course, we tend to see more people with the disease because people are living longer, and this is a disease that affects the elderly. So age is certainly something which would signify an increase in your risk of getting the disease. I won't go into all the other risks as well, but certainly if we're trying to apply some percentages to it, we could say that, well, actually 5% of all people with Alzheimer's are below the age of 70. So comparing that to 30% of everyone with Alzheimer's disease is between the age of 70 to 80, and 65% of all people with the disease are over the age of 80. So it's certainly a correlation there with age. So in terms of Alzheimer's disease, we are thinking about some of the gross anatomical changes that occur with the disease, and so to do that we're going to move on and look at a couple of images. First of all, we're going to look at a normal healthy brain slice. And I want to draw your attention to everything that's normal and healthy about this brain that makes it so you can tell very easily when things are diseased. First of all, we've got a few key landmarks to spell out here. First of all, hopefully you can see, I'm drawing around part of the cortex here, and you can see the difference here between the grey matter and the white matter below. So this area in blue, this is called the cerebral cortex, and you can see that that is very well defined with the layer below, which is a subcortical region. So that's subcortex just meaning below the cortex. You'll also see in here we have a left and a right hemisphere, which is separated by this structure in here, this red structure, that's called the corpus callosum in there, and below that we can see some spaces, and these spaces in here are the ventricles where cerebrospinal fluid would travel. Notice how symmetrical they are, notice how they appear fairly the same shape on left and right. If we just go back to the cortex briefly, you'll notice that the cortex consists of some bumps on the outside, so these areas on the outside in here, and these are known as the gyri or the gyrus, and the intervening grooves, which are these long channels in here, which you can see increasing the surface area. We can see them down here as well in the temporal lobe in there. These are intervening grooves, are known as the sulci. Notice how they are very close and tightly bound together. There's no gaps in between them. If we go back and look at the subcortex in here, we'll notice that in and amongst the subcortical area, which is all this white matter in here, we'll notice that there are some areas that are dark again. So in here we have some what we call subcortical nuclei, and this one together with one in there, together with this one in here, they all make up a structure known as the basal ganglia. And in here we have the thalamus, different nuclei associated with the thalamus, and in here we have the red nucleus as well. Where we see the white matter running in between, in there, very white in there, this is all axonal fibres. These are the long axons that travel probably either to different parts of the cortex, to different hemispheres, or even down into the spinal cord. And they are heavily myelinated and therefore give this white appearance. It's the cell bodies of those neurons that occur in the cortex and anywhere where we see the grey matter, so that's where we expected to see the nerve cell bodies. So this is our general appearance of a normal healthy brain with a few key structures pointed out. Let's now have a look at a diseased brain, which is a similar brain slice. Here we can see massive differences. First of all, the biggest difference, which is how wide these ventricles are. Look at the atrophy. So atrophy is just a term for reduced in terms of mass or tissue volume. We can see that now that the ventricles are not only asymmetrical, but they've widened out as well. Notice that the cortex that we could see really well defined on the outer layer on here, we can no longer see a contrast in here between the cortex and the subcortex. So we can no longer see the cortex. So here we can see that the cortex has atrophied significantly. The gyri I was talking about have widened out, so we can see the tips of them here. We can see how they've widened out, and also the sulci, the intervening grooves. Notice how again we can now see gaps in between them in here, which we couldn't see before. They are very large and give what's known as a walnut-like appearance to the shape and the contour edge of the cortex as it comes round. In particular, one area to atrophy majorly is this lobe down here. This is called the temporal lobe, and the temporal lobe seems to be affected fairly early on and more severely than the rest of the cortex, although atrophy is generally referred to as being global all over the surface of the brain, but the temporal lobe is certainly more severe. Generally speaking, the grey and the white matter is affected equally in the atrophy, but more commonly are the effects on the basal ganglia. So notice how in and around this area we had some dark, very well defined subcortical nuclei that belonged to the basal ganglia in here and in here and in here and around here. We can no longer see those, so we get significant basal ganglia atrophy, which would eventually lead to some motor problems, although Alzheimer's disease isn't typically known for motor problems. And one of the other structures that tends to be affected, which I didn't point out, so if I go back to the previous slide on the healthy brain, one of the areas that's really key is this structure in here, which is called the hippocampus. Notice how they're fairly symmetrical, really tightly bound together on each side. If we go to our diseased brain, notice how these now have widened out and really atrophied, so the hippocampus has atrophied significantly. So here we can see overall atrophy that's fairly global. We can see the subcortical nuclei have been affected. The temporal lobe seems to be affected more than any other region in terms of the cerebral cortex, and most significantly the hippocampus in here on each side, deep inside the temporal lobe, has been affected more significantly as well. So let's compare and contrast some of the overall symptoms of Alzheimer's disease with some of the other types of dementia that we talked about early on. Let's just label this though nice and quickly. Number one in here, this is the frontal lobe. Number two is actually a sulcus down here. If we just draw that in a bit thicker, this is known as the central sulcus, and this marks the transition from the frontal lobe in blue to this area in kind of maroon red, which is the parietal lobe. Number four down here is another sulcus. Again here this is called the lateral sulcus or lateral fissure in here. And number five represents the temporal lobe, which is in green, and 6 at the back is the occipital lobe. So generally speaking, Alzheimer's will progress in a fairly predictable way. The first thing to go will be probably the hippocampal area deep inside the temporal lobe, and for that reason we associate the symptoms of Alzheimer's disease with memory loss. So this will be memory loss initially short-term memory. The hippocampus's job is to convert short-term memory into long-term memory. This is a process called consolidation. Long-term memories are stored throughout the cerebral cortex globally and bring together different types of memory: visual, auditory, sensation type memory, smell. But certainly in order to keep hold of short-term memories before they're stable long-term memories, we need a functional hippocampus, which is why we find in Alzheimer's patients that they tend to have good memory for autobiographical events, what they did as a child, or memories from a long time ago, but they tend to have a very poor short-term memory, remembering where they put their keys, or maybe remembering the name of something that in a sentence a moment before. The other thing that tends to get affected is the area in green, the temporal lobe. That leads to issues surrounding language if it's the dominant hemisphere. So one of the other major symptoms here is word finding, the idea that somebody with Alzheimer's disease may struggle to think of the right words to say in a sentence, or may be very slow in formulating a sentence and often may remain quiet for long periods of time. The other area that tends to get affected is an area up here in the frontal lobe. The frontal lobe is associated with our personality and our working memory and our ability for problem solving and cognitive skills. And the frontal lobe is affected, and therefore we start to see a lack of reasoning and problem solving and a general lack and slowness of cognitive ability in an Alzheimer's patient. So we see problems with cognition. Some areas of the brain are spared in Alzheimer's disease, and we're not really sure why, but areas in here, so this is the primary motor cortex, and in here, just posterior to the central sulcus, we have the primary sensory cortex. They tend not to be affected, so any problems that we tend to have with motor control or motor aspect of motor control are down to basal ganglia dysfunction. Remember, they are the areas in the brain which we saw really well defined in the healthy brain. They were these subcortical grey areas, well defined. In the damaged brain, in the atrophied brain of an Alzheimer's patient, we could not see those at all. They were very, very difficult to see, barely visible. So issues surrounding motor problems tend to be due to the basal ganglia and not due to the strips of cortex involving voluntary motor control, or also involving sensation as well. Also, what tends to be spared is the back of the brain, this area in yellow, number 6, the occipital lobe tends to be spared, so we tend not to see too many visual disturbances. It is possible, but visual disturbances tend not to come very early on in Alzheimer's patients, but it is possible to get visual hallucinations. I just want to finish by quickly talking about the differences between Alzheimer's disease and something quite similar, which is frontotemporal dementia, formerly known as Pick's disease. The major difference between the two is that with Alzheimer's disease we get memory loss, and often with frontotemporal dementia we tend not to get memory loss. We tend to get the problems with the frontal lobe first, so the behavioural problems, the personality problems, they tend to come on first, and we get fluctuations in cognition. So often we don't get a very steady, slow, progressive decline. We tend to get fluctuations in cognition from day to day. We can also now compare that with something like dementia with Lewy bodies, which tends to come about through Parkinsonism. Lewy body dementia occurs through these small intracellular inclusions that affect functioning neurons, and we tend to get problems involving visual hallucinations. So visual hallucinations tends to be more involved with dementia with Lewy bodies and therefore affecting the occipital lobe. So there you are, a quick summary of the main anatomical changes that occur in Alzheimer's disease and comparing and contrasting a few of the symptoms as well. Bye for now.